Dr. Jatin?
Yes, I'm there. We are
Okay.
waiting for Dr. Ekta Girdhar, sir.
Yes, sir. No problem. Yeah, please carry on.
She is in attendee, so she's just coming to panelists to present actually.
Yeah. So can you ask everyone to actually, whoever is there in this panelist, box to rename them actually
Yeah,
better?
I have. We have few of us have already done that. So I think the rest of us, all the faculties can rename themselves so that we know who is who. Um, Dr. Ekta, are you there?
Dr. Jatin, I am again able to see her in the attendees list. Maybe I'll just quickly give her a call.
Yeah, if you can please.
Yeah, I'll talk to her.
All
Sure.
that,
Yeah,
if you can.
Yeah, Dr. Jatin, I tried calling her, but I guess she's already on a phone. It's on hold. So maybe somebody from our team only is talking to her. I'm not sure.
Dr. Gunjana, you send her link, right? Dr. Dhiren,
Yes, I just received call from Ekta. So the link for joining the panel, this thing group that was sent to her, that isn't working. So, and if she tries to join again through the web link, then she is only able to join as an attendee.
I think the same link works for all of us, so I don't see the reason why she can't join.
Or else what I'll do is the link that all of us have, maybe I'll forward that link to her. I don't know if that
you can
works.
forward that link.
Yeah, sure.
Let her leave the meeting first, then rejoin it from the link.
No, she left the meeting once already, but then it was not working for her. I'm just sending the link that I have. I'm sending it to her.
Okay.
I have forwarded her like the link that I had, and I have asked her to join through that link. She'll be doing it
Okay.
soon.
I think I've just talked to her. She's having some issue because she said she's able to join as an attendee and
Yeah.
not as
Yeah.
this. I've forwarded her the link again.
But she needs to log out as an attendee.
No, I can see that she has already left from the attendee group. Now
Mhm.
she's no longer there in that group. So
Hello,
yes.
ma'am. Sorry, sir, for the delay.
So
Okay, no problem. Ekta,
Ekta, you
can
have
you?
joined.
Yes, ma'am.
Can you just rename yourself?
Yes, ma'am.
I think you have joined Ekta, right?
Yes, ma'am. Yes, sir.
Okay.
So shall we start?
She needs to be made host, isn't she? Otherwise, she can't share her screen. So, which one she needs to rename? Okay. I don't know who can make her a host so that is there.
I think only Debarun can make her a host.
Okay.
Probably
Yeah,
she can.
Yes.
She has the rights.
Are you able?
Okay.
Okay, yeah.
Okay. Okay. So, good evening, everyone. Welcome to the NOEL series of lectures. Today we are going to have a interesting case presentation on one of the very commonest condition in the preterm neonates, that is a necrotizing enterocolitis. To present this case, we have Dr. Ekta Patel. She is a fellow at Arpan Newborn Care Center, Ahmedabad. To moderate this session, we have very senior Dr. Ashish Mehta, sir. Sir messaged that he will be coming a little late, so Dr. Dhiren Thakkar, who is a senior neonatologist at Arpan Newborn Care Center, he is going to moderate till then. And to as an expert, we have ma'am Dr. Shilpa Kalane, ma'am. She is a senior neonatologist at Dinanath Mangeshkar Hospital, Pune. So
Good evening, everyone.
Good evening, everyone. So without much delay, I think we should get start with the case presentation. So Ekta, it's all you can share your screen and get on with it. Thank you.
Good evening, everyone. Sorry for the delay. I'm now presenting a case on a preterm with an neonatal enterocolitis. My baby is baby of a single male with a gestational age of 34 plus 3 weeks, having a birth weight of 1.740 kg and delivered with the LACS on 26th of September. Currently, baby is 14 days old, post-menstrual age of 36 plus 2 week on room air with post-operative day 4. Moving to the antenatal history, maternal details, baby is born from the non-consanguineous marriage through a spontaneous conception to a 29-year-old gravida 4 para 3 abortion 1 living 2 baby. Her LMP was not known, and the expected date of delivery was 5th of November 25 through a dating scan. The mother's blood group is A positive. First trimester history, mother is booked at PHC at 8 week of gestation. Antenatal USG scan was done and gestation age was confirmed. There were no history of rash, fever, bleeding, excessive vomiting, no history of diabetes mellitus or hypertension. Other blood tests, complete blood profile, viral markers, VDRL were negative. Mother was on folic acid supplementations. Second and third trimester history, mother was taking iron and calcium supplements. 2 doses of tetanus diphtheria toxoids was taken. There were no history of fever, burning micturations, rash over body, no history of gestational hypertension. diabetes mellitus, no history of bleeding or spotting PV. There was no history of leaking PV. Anomaly scan was done at 20 week of gestation and was normal. Last Doppler scan was normal. Natal history. A baby was born by elective LSCS delivery for scar tenderness on 26th of September at 5:15 p.m. at a private hospitals. Baby cried immediately after birth. Apgar score was not available. Birth weight was 1.740 kg, which was less than 10 centile according to Intergrowth 21 chart. In view of low birth weight, baby was admitted in NICU at private hospital. In postnatal history, on day 1 of life, after birth, baby was kept in NICU. IV fluids and other supportive management was started, and RT feeding was started with the top milk. Baby developed complaint of vomiting and abdominal distension, so was made NBM on day 2 of life, and then on day 3 of life, as abdominal distension was increased and there was a high CRP, so baby was referred to higher center for further management.
Can we wait here, Ekta?
Yes, ma'am.
Can you go back to the previous slide?
Yes, ma'am.
Okay. So this baby, you're saying is preterm, very and low birth weight, and has GI symptoms on day 2 of life, right?
Yes, ma'am.
Okay. It is vomiting and abdominal distension.
Yes,
Right.
ma'am.
So can you elaborate on just vomiting here?
Yes, ma'am. According to the relatives, they had told us that the baby had some multiple episodes of vomiting. Proper detailed history we cannot get from the relatives, but they were saying that baby was not able to tolerate the feeds, and they were told that there is abdominal distension.
Why is this history important, vomiting history? Suppose
Yes,
there is a
ma'am.
patient history of vomiting. What are the things you would like to elicit in that patient?
Yes, ma'am. Ma'am, we have to elicit the character of the vomiting and the color of the vomiting. If the vomiting is bilious, then it may suggest it is obstructions, or if there is a multiple episodes of vomiting, then can be due to any metabolic error of inborn error of metabolism. Obstructions can be there. Then we have to see for the another things like is there present of abdominal distension, meconium is passed or not, to rule out the obstruction and also the anorectal malformations.
I tell you the color of the vomiting, you tell me where is the problem. If it is white vomiting,
So,
if it's
sorry,
only
ma'am?
milk, yes, I will tell you the color of vomiters and you tell me where
Yes.
is the problem. If it is milk,
Okay, ma'am.
if it is milk,
If it is milk, then
it could be
it may be
physiological, it could be
upper
pathological.
GI
No, it could be physiological, it
Yes,
could be
it
pathological,
can be
correct?
both.
Yeah. Okay, if it is curd,
Yes, ma'am.
if it is curdy,
It is
then
a physiological.
or pathological based on the other history we would like to elicit, correct? So if it is yellow or green, then
There can be obstruction or any malformation, intestinal malformation.
where is the problem? If it is yellow or green vomiters,
Then it can be problem in a small below the level of duodenum.
yeah, so not below the level of
Below the
duodenum,
stomach.
no, not below the below the stomach, it is below the ligament of Treace or the second part of the duodenum, right?
So, yes.
So if it is the fresh blood, then
Uh,
if it is fresh blood,
it can be a maternal blood present in the baby stomach.
or it could be esophagus. If it is altered blood,
If it is altered blood, it may be a presence of aspiration of the maternal blood, and also it can be due to uh, any feed intolerance due to in NEC.
the stomach, okay,
Yes.
could be the origin could be the stomach, right? Now tell me that any patient coming with history of vomiting, what else you would like to know in that patient apart from the color of the vomitus? Anything else? Whether the baby is past meconium, that you already mentioned. Whether the baby's abdomen is distended, that also you mentioned. Anything else you would like to know?
The character of the vomiting, it is projectile or non-projectile type of vomiting.
Do the kids have projectile vomiting? The neonates?
No, ma'am, sorry.
Less likely. Okay, they do not have. Okay, unless in certain very situation, but otherwise on day 2 projectile is little unlikely. Okay, anything else?
Association
Frequency.
with the feeding.
Absolutely, absolutely. Why is it important? Association with feeding?
It can be reflux of the feed because the in preterm babies there is a low lay stone in the esophagus, so there are more chances
Okay,
of the
so
reflux.
could be because of reflux, right? Okay, anything else you would like to know? If there is history of vomiting and abdominal distension, anything else you would like to know in this baby?
Mm,
The patient has come to an ER. The patient is saying that my baby has vomiting and I feel the abdomen is full. Anything else you would like to know after eliciting this history?
does baby has
So you would like to assess the sickness level of this baby also, right?
yes.
How would you assess that? What you would ask?
Is baby is taking feeding well or not, and if baby is active or has
Yes. So
reduced in
simple, cry,
activity.
tone, and activity. Correct?
Correct.
Yeah. So why is it important to know the sickness level?
Yes, ma'am. If there is any obstruction, if there is any obstruction, or if it is the vomiting is due to the inborn error of metabolism,
Anything common than
there can
inborn
be
error of
encapsulation of
metabolism? Anything common than IEM?
no. Uh, Ma'am, any obstruction, the baby can have.
So sick baby and non-sick baby, okay? So baby who has got systemic illness is bound to be sick, okay? And the systemic illness is typically sepsis,
Yes,
NEC, okay? And IEM, right?
yes,
If
ma'am.
it's a non-sick baby, probability is surgical abdomen, which is not yet got complicated, right? Anything else you would like to know if there is a history of recurrent vomiting? Any complication of recurrent vomiting?
Uh, pattern of the weight gain of the baby. Uh,
And
it
oliguria,
yes.
right? Okay. Now this baby has presented on day 2 of life with vomiting and abdominal distension. Now because you have the other history here, you tell me this patient you see in ER with vomiting and abdominal distension on day 2 of life, what specific antenatal history you would like to rule out? Antenatal history and intranatal history.
Intranatal, is there any history of birth asphyxia? And antenatally, is there a history of chorioamnionitis of mother, that is fever or foul smelling liquor was present or not, and leaking for more than 24 hours was there or not?
Okay. Any other history you would like to know?
Then,
So baby presented with vomiting and abdominal distension on day 2 of life. What could be your difference?
it could be no, transient feeding
Differential?
intolerance. It could be transient feeding intolerance, or any intestinal obstruction, can be
Suppose this
a
is surgical.
congenital.
Yeah. Suppose this is surgical. What prenatal history you would like to know?
The antenatal scan.
What specific thing in
The
antenatal scan? What
Is there
happens
a
when there is a GI obstruction?
polyhydramnios, or is there
Absolutely.
any poly?
Okay. Is there polyhydramnios? Can tell you that the baby is likely to have in GI obstruction, right?
Yes, ma'am.
Okay. If there's oligohydramnios, can that have implication on the gut behavior postnatally?
Uh, it can be because if oligohydramnios, there can be placental insufficiency and it can lead to gut uh, poor perfusion and it may lead to feed intolerance.
Okay. What any specific antenatal medication history you would like to know if there is feed intolerance postnatally?
Mother had taken NSAIDs like indomethacin or not.
Absolutely. And why would she take indomethacin?
Because the
Do obstetricians give indomethacin?
mm, no, sorry, ma'am.
When there is
No.
amniotic fluid problems, do they give indomethacin?
Uh,
Okay.
sorry, ma'am.
So, of Doppler,
Yes.
Doppler, you would like to know when the
Yes,
patient
ma'am.
comes like this?
Yes, ma'am.
How is it
Yes, ma'am.
important?
If there is a abnormality in Doppler flow, if there is a absent or in later stages, if it is a reversal of the flow, then it can lead to a gut. Yeah, there is a first organ to be impaired is gut. So there is a gut ischemia is present. So there is a many more chances of developing a feed intolerance in these babies.
And magnesium sulfate lead to problem
Uh,
of feed intolerance?
yes, ma'am. It can.
Okay. So when you when you have a baby with history of vomiting and abdominal distension on day 2, your antenatal history is very important. So because you already knew this case, no, so you could have mentioned there is no history of, right? No
Yes.
history of polyhydramnios, no history of decreased fetal movements, or poly or oligohydramnios, decreased fetal movements, choriamnitis, perinatal asphyxia. Then we know that something is related,
Okay.
right?
Yes.
Okay. Yes, you also mentioned that this baby, okay, that we'll talk later. Okay, so this baby was born outside. We do
Yes,
not
ma'am.
have details of delivery room management.
Yes, ma'am.
Why is it important?
Uh, it is important is be as the baby is late preterm and if the baby is not cried and what was the mode of resuscitation and during delivery room the thermoregulation is very crucial is very important.
Pertaining to this case, one intervention which is important for
Anal
feed
patency
intolerance.
and
One is
uh,
anal patency. One delivery room intervention which protects the baby from feed intolerance. One delivery room intervention.
early early given baby to mother.
Okay, IKMC.
Yes.
Good. DCC,
Yes, ma'am. Yes, ma'am. Delayed cord clamping.
right? Okay.
Yes.
Okay. So now, since we know now the history of vomiting and abdominal, so how is it important to get a clue of probable differential? So, can you tell me in this particular patient what is the history of vomiting, the ODP of vomiting?
Ma'am, the relative had told us that on day 2 of life, the baby had developed complaint of vomiting, and it was gradually associated with the abdominal distension. Then over on day 3 of life, the vomiting was increased, and they had to stop the feeding, and then they were referred for further management, and they had done some investigation. They
Okay.
told us that
Okay.
the one investigations was
Okay.
there was a high CRP was
Okay.
there. So
Okay. 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 So you mentioned that the baby was started on top milk. Can you
yes, ma'am.
clear that what top milk is this?
Ma'am, formula milk was given.
Okay. He was started on formula feeding. The baby was started on formula feeding, right?
Yes, ma'am. Yes,
Okay. So
ma'am.
yeah, we proceed.
Okay. Uh, On day 3 to 5th of life, baby admitted at the tertiary care level NICU. On admission, baby had oxygen requirement and grunting, so baby was put on a CPAP support and gradually went to HHFNC support over 2 days. And then, as baby is maintaining saturation well without respiratory distress on room air by day 6 of life, baby
Okay,
was kept and
hold on, hold on.
yes,
A baby who is presenting with vomiting and abdominal distension, why the baby should have distress?
Ma'am, there can be a possibility that the baby was transferred from one center to another center. The baby, due to the abdominal distension, there can be a respiratory distress. Second thing, there can be a sepsis, or which can be present as the oxygen requirement, and the due to the distension and painful condition, it can lead to grunting in the baby.
Anything else?
Uh,
One is abdominal distension, second is sepsis. Anything else?
and as the baby is also a late preterm, it can uh,
Can acidosis also cause grunting, the
yes, ma'am.
distress?
Yes, ma'am.
Okay,
Acidosis also.
okay, okay, good. Okay, proceed.
Abdominal distension. Blood investigations done over there showed a thrombocytopenia and high CRP. IV fluid and IV antibiotics were started after standing blood culture report. Abdominal X-ray was done, which was suggestive of multiple air fluid level, suggestive of intestinal obstruction. A USG abdomen done, which was suggestive of dilated jejunal and ileal loop scenes with a reduced peristalsis, dilated loops measuring 15 to 16 mm in caliber, mild free fluid with internal echo seen in right iliac fossa, interbowel region, edematous and hypoechoic wall of distal ileal loops noted with ill-defined margin of bowel wall. Pediatric surgeon reference was done and they were advised surgery, so relatives to our unit.
Okay. So
The
wait.
lab investigations, yes, ma'am.
Yes, continue.
The lab investigations done over there on 29th, it was having a high CRP, and on repeated CBC level, the platelet count was significantly fallen to 46,000, and this X-ray was suggestive of multiple air fluid level, which were done at another private hospital.
Hold on here. So
Ma'am,
now, wait.
sorry, ma'am. Can I take 1 second? Because
Yes,
actually
please.
Dr. Ashish sir has joined. So, sir, please welcome to the NOEL program. Just wanted to introduce.
Good
I
evening, sir.
conveyed your message that you are going
Go
to
ahead, go ahead.
elaborate.
Jatin, let them go ahead.
Sure, sure, sir. Thank
Yeah.
you.
Please, thanks.
Yeah. Ekta, can you read this X-ray for me, for all of us? Hello,
It is a anteroposterior erect X-ray involved. There is a multiple air fluid level seen in the abdomen. It
well
can be
centralized,
it
well
is suggested.
exposed.
Yes, it is a well exposed, and it is a well centralized. There is no any abnormality seen in a lung level lung film. In abdominal part, there is a multiple air fluid levels are seen. Uh,
Okay. So what is your differential diagnosis?
Sorry, ma'am.
Just based on the X-ray?
It can be intestinal obstruction. Mostly it can be small intestinal obstruction, or
Okay. Why do you say it is? How do we differentiate on X-ray that it is the obstruction is at stomach level, duodenum, upper GI level, lower GI level,
yes, ma'am.
or large intestine level? So if it is, how do we differentiate that? When there is a single bubble, where is the obstruction?
It at the stomach level, below the above the duodenal level. If at the duodenal level there is obstruction, then we can see the double bubble appearance, and below the duodenum, if small intestinal below the duodenal level, if there is obstruction, there can be multiple air fluid levels will be seen.
Gastric outlet single bubble, duodenal obstruction double bubble, jejunal triple bubble. Okay. And if it is jejuno-ileal level, then it could be multiple,
Multiple.
you can dilated bowel loops. Okay. Large intestine dilated would be a large bowel obstruction.
Large.
Okay. Also, very important to comment on gas in rectum. Okay. If there is a gas in rectum or not. Okay.
Yes.
So how do we decide from here whether this particular baby, so what is the indication for upper GI study and lower GI study in any surgical abdomen?
For
In which particular cases you would do lower GI study?
for low
Any particular case? So at least pathology in rectoanal area, right?
yes.
We want to know what is whether the anorectal area is okay or not. We want to know whether the large intestine is okay or not, and to some extent, ileocecal junction, right?
Yes, ma'am.
Okay, so in that day we can go for lower GI, and the upper GI is for the, as the name mentions, it is for the upper GI.
For upper.
Correct? Yeah. Okay. Proceed.
On receiving baby in our unit on day 6 of life, baby was maintaining saturation on room air without any respiratory distress. Vitals were temperature was 36.8 degrees centigrade, heart rate was 156 per minute with a good volume, respiratory rate was 52 per minute, and capillary refill time was less than 3 seconds. GI system there was a abdominal distension present with visible dilated veins and redness over right iliac fossa. There were bilious RT aspirates present. Ray systemic examination was normal. After admission, IV antibiotics were continued after sending blood culture in view of high CRP and thrombocytopenia. IV fluid and other supportive measures were continued. Injection platelet concentrate were given in view of thrombocytopenia. On day 7 of life, PICC line was inserted for total parenteral nutrition. USG abdomen done, which was suggestive of gas and fluid-filled bowel loops with sluggish peristalsis. Mild amount of intraperitoneal fluid collection is seen and predominantly in the perigastric and the perisplenic region. Pediatric surgeon reference was done.
Okay, wait, stop. Can we go back to the previous slide?
Yes.
Okay. How do you decide antibiotic for any surgical abdomen case or any abdominal case? Which the choice of antibiotic?
Yes, ma'am. For any surgical condition, we can give the injection
What is your unit protocol? How do we decide antibiotics?
Yes, ma'am. Ma'am, in our unit, the first line antibiotic were Tazac and Micacin. But this baby had received the already injection maropenam and colistin at previous hospital, so we had continued with the same antibiotics, and we had taken a second blood culture before starting the antibiotics.
Yes, so generally choice of antibiotic is broad spectrum. Also, it also becomes it is also depends upon your unit policy, right?
Yes, ma'am.
Whether you would add anaerobic coverage here or you won't
Yes,
add
ma'am.
anaerobic coverage here.
Yes, ma'am. If after a surgical procedure, we can add the anaerobic coverage with the injection matronidazole if required.
Okay. So if the peritoneum is open, then you may consider that. However, yes, again, it is a unit policy,
Yes.
right? What is your take on starting TPN in a septic baby?
In our unit, we start with the protein with the initially with the 1.5 gram per kg per day, and then we gradually upgraded to maximum dose of 3.5 to 4 gram per kg per day. We start the fat in very low birth weight babies and extreme low birth weight babies. If the sepsis is present, then generally we start with the protein, and the fat is considered if the baby is very we having a very extreme low birth weight.
So TPN generally, so what TPN would you give on day 7 for this particular baby? Tell me what protein you would start with?
We had start with the amino vein at a 3.5 gram per kg per day.
Just tell me protein. We don't talk about brand names here. So just protein.
Protein
So how much you would start?
with a 3.5 gram per kg
Okay,
per day.
excellent. What about lipids?
Uh, we can the lipid we can start with the at 2 gram per kg per day, and with maximum to 3 gram per
Okay.
kg per day.
How much GR you would like to set here?
Uh, Ma'am, to maintain a blood glucose level between around 80 to 125, we start with the around
Good.
13%,
So you
and
want to
then
maintain euglycemia. Excellent. How much sodium you want to add?
just sodium should be added at 3 to 4 milliequilibrium per kg per day to
Potassium?
maintain a normal sodium level.
Potassium?
Potassium at 1 to 2 milliequilibrium per kg per day.
Okay. MVI you would add or no?
Yes, ma'am. As this baby is nil by mouth, we add the multivitamin.
So MVI is part of TPN, okay? What about magnesium, calcium you would add or no?
Ma'am, we add the calcium in the in the IV in the TPN.
Okay. And magnesium?
No, ma'am.
Okay. So magnesium is also part of TPN, can be considered. Okay. Okay.
Yes,
And
yes, ma'am.
okay. And okay, what about phosphorus?
Yes, ma'am. We add the phosphorus in in some babies. In these babies, we had not yet started it, but we can add it in the TPN.
Which particular specific babies you would consider adding phosphorus? And how would you add that?
Ma'am, if the baby is kept nil by mouth for prolonged period, then we add this phosphorus. Uh, it can be added in the protein, and it can also be added in the IV fluid. Uh,
Okay. So so provided you don't add calcium in the solution because it
yes,
leads to
yes, ma'am. Yes,
precipitate,
ma'am.
right?
Yes, ma'am. Yes,
Okay.
ma'am.
So specifically preterm VLBW you would consider adding phosphorus, right?
Yes.
Okay. Can TPN be given through peripheral line?
No, ma'am.
It can be given as far as you're maintaining the osmolarity. Okay, if as far as you're not crossing the percentage dextrose more than 12.5, it can be
12.5.
given through peripheral line. Okay. The last question on TPN, how much TFI you would decide for this baby? And how
Uh,
would you decide?
Ma'am, this baby is around at 11th day, at 7th day of life, we can give around 150 to 160 ml per kg per day with in this baby.
Okay, 150 ml per kilo per day. However, you also would judge the babies because this baby is going to
With
have
also we have
unstable hemodynamics. No, the fluids are going to get shift. So he maybe have edema or so that also you would consider. So you'll have to consider dry weight here, right?
yes, ma'am.
Okay. Okay, we can proceed.
These were the reports done at our setup. The on admission, the platelet counts were 33,000. Then we had transfused 3 platelet concentrate, and after that the platelet were normalized. CRP was on admission, it was 119, and it was increased, and then it was gradually started to decreasing. The rest urea create and that was level were normal. The X-ray on admission done over our setup was shown here. There is some dilated bowels we was seen in the abdomen.
Okay. Dilated or thick?
It is thick, and we had done some. We had done also second X-ray. It was also showing the bowel at same position. Uh, I
So
had
when do
not.
you say that the bowel loops are dilated and they are thick?
Uh, the hostrations are minimal, and the diameter of the bowel will seen large.
Okay, excellent. That's for large intestine. Okay. But otherwise, so if the diameter is more than 2.5 and the thickness is more than 3 millimeter,
3
then it
millimeter.
is, yeah, then it is abnormal. Okay.
Yes,
Yeah. Then we can proceed.
On day 11 of life, baby was operated once platelet counts were normalized. Intraoperative distal ileal bowel seam sloughed out with a multiple perforation. So ileal resection was done, approx 20 to 25 centimeter, and ileostomy was done. Biopsy of resected ileum has been sent for histopathological evaluation. 1 unit of packed RBC transfused intraoperatively. Uh, Post-operative course. Baby is on room air. Post-operative baby required injection, normal saline bolus, and inotropic support for a low blood pressure, and it was gradually omitted over 24 hours. IV antibiotics were continued.
What do you think? Now we have the X-ray finding, we have the clinical progress, we have the intra-op finding also. So what are we dealing with here now? So this baby had vomiting, abdominal distension, then became sick, okay, and then had necrotic bowel. What is this?
It is necrotizing enterocolitis.
Okay. Why 34 weeker? So okay, 34 weeker can present with necrotizing enterocolitis, but why on day 2 of life? What do you think? Any take on
Uh,
that?
yes, ma'am.
What is
Generally
the
the
ideal
present.
presentation?
Yes. The ideal presentation is generally around in around 10 around 8 to 12 days of life in preterm babies. But as this baby is late preterm and they had started with the formula feed immediately, it can be a possible region, and there is a sepsis, there is a high CRP, and so it can uh, possibility of
So how was the baby for first 2 days of life?
uh,
He was good?
on first day of life, the baby was only admitted for low birth weight. There was no any distress or such things, but on day from day 2 the baby had started developing symptoms.
For sepsis to develop as NEC, the baby has to be sick from the beginning,
For
right? Here
beginning,
the
yes,
baby was okay, had abdominal symptoms, and then became sick, right?
yes,
Have you heard about something called cardiac induced mesenteric hypoperfusion syndrome?
yes, ma'am.
What is it?
If there is any congenital heart disease present in the baby, then it can lead to poor perfusion due to stealing mechanism, and it can lead to the poor perfusion of the gut, and it will can lead to the feed intolerance and NEC.
Can it happen in any other baby who has low cardiac output without congenital
Yes,
heart disease
yes,
also?
yes, ma'am, yes, ma'am.
Yeah, so the primary pathology is low cardiac output,
Low cardiac output.
correct? Okay, but we feel that this is necrotizing enterocolitis. Any probability that this baby has primary surgical abdomen and then it has led to necrotizing enterocolitis?
uh, yes, ma'am, it
Ileocecal junction is very
can
typical
be,
of NEC. Can that be
can be,
any other surgical pathology that can present in ileocecal junction?
uh, yes, ma'am, it can be because the baby was initially good. It was not any symptoms were there. So any ileocecal malrotation was there.
The malrotation will be seen on sonography as well as it could
Sonography,
be,
yes,
yeah,
ma'am.
it could be, it can be picked up on intra finding also. Can intussusception, volvulus,
Volvulus. Yes,
okay,
ma'am.
or meconium, just meconium
Plug,
ileus,
meconium.
meconium plug, can it present like this?
Uh, in meconium plug, it can be present like this, but there is a delay passage of meconium will be there. In this baby, the meconium was passed as per relatives history, so it cannot be there.
Okay, so meconium plug can present anywhere. It can be in large intestine, it can be in an ileocecal junction, right?
Yes,
So, maybe anything, but even surgery. So this could be NEC, but day 2 is little unusual. So it could be primarily surgical abdomen, which has led to which the complication of NEC, right? So we have to keep that differential,
yes, ma'am.
right? Okay. You also mentioned there was a mass and tenderness in the right the iliac fossa, right? When the baby
Tenderness,
can
yes.
it be neonatal appendicitis?
It can be, ma'am.
It's a rare thing, but it can happen. Okay.
Yes, ma'am.
Okay. Proceed.
1 unit of platelet-rich concentrate given on post of day 3 in view of thrombocytopenia again. Currently, baby is NBM and on full IV fluid and receiving the protein at 3.5 gram per kg per day. The ileal loop biopsy report were suggestive of marked intramural hemorrhagic necrosis with the inflammatory granulation tissues and moderate acute and chronic inflammatory infiltrate. The
Okay.
So, summarizing it, the baby is late preterm, 34 plus 2 weeks, with a low birth weight of 1.740 kg, small for gestational age, with the sepsis and necrotizing enterocolitis with shock.
Okay. So, and what is the risk factor for this NEC now?
It can be a surgical and
So, consistent risk factor is prematurity. Second, you are
premature.
mentioning it is small for gestation age. We do not know the reason for small for gestation age, right? And
Yes.
then you are saying the history of formula feeding was also there.
Formula feeding, yes.
Yeah. So 3 factors, and we do not know about the underlying surgical abdomen, but that surgeon could have picked up intraoperatively, right?
Yes, ma'am.
Okay. So now this patient is present on day 2 of life. Now, since you have intraop finding, but otherwise, how would you differentiate this patient with spontaneous from spontaneous intestinal perforation?
Yes, ma'am. In spontaneous intestinal perforation, there will be baby will be not sick. The conditions will be acute, symptoms will be acute. There will be uh,
There would be perforation.
and the perforation and there will be the involvement of not the whole mucosa was there in NEC. It is the whole mucosa is involved. Then
So it is called focal intestinal perforation. There would be perforation. So if this baby had perforation, then that could have been a differential, right? And intraoperatively, you would see rest of the intestine is okay. Can this be FIP? The baby had perforation, then it was sealed by the surrounding intestine, and then it presented as mass.
yes, ma'am.
Is there a probability? Possibility? Can be.
Yes, ma'am. Yes,
Right? Okay. Okay. So tell me, so now when are you planning to start feed for this baby?
Ma'am, we have to, the main thing is we have to give the rest to the bowel. After proper rest and around 8 to 10 days, and also we have to see for the aspirate of the baby, RT aspirate, then the stoma output, and other features like the baby's general conditions and perfusion of the baby.
Very good. Okay, so the baby's clinical condition, as clinical condition improves, then you would consider starting feed. That is what you are trying to say, right?
Yes, ma'am.
It is not by the days now. So if the
Yes,
baby improves, then you would definitely give trial feeds. What milk you would prefer?
The preferable milk is mother's own milk, and if it is not available, we can give it the human donor milk.
Okay. And how much you would like to start?
We can initially start with the minimal enteral feeding, and then we can gradually increase
I'll
by
give you, so I'll tell you 15 to 20 ml per kilo or 30 to 40 ml per kilo. How much you would like to start?
initially we 15 to 20 ml per kilo we start, and then we'll gradually increase by around 30 ml per kg per day.
Okay. So this particular is a high risk patient. Maybe you would start with trophic fees 10 to 20 ml per kilo, and then you can grade up based on again your own unit protocol by 15 to 20 ml per kilo. There is something called SIFT trial. Have you heard about that?
Yes, ma'am.
What is it?
It is a trial in which they had compared with rapid escalation of the feeding at a 30 ml per kg per day versus a slow escalation at around 10 to 15 ml per kg, and they had showed there is a no any significant difference in chances of developing NEC.
Okay. Okay. Good. Can you just tell me the long form of SIFT trial?
Uh, it is
Speed of increasing milk feeding
slow.
trial.
Yes.
Okay. Okay. Tell me, so how much maximum feed you would try to like to reach in this baby? Maximum feed?
Uh, it can be 130 to 150 ml per kg per day.
130 or 150?
130 ml per kg per day.
Okay. So we can go as high as 150. You can cross 150, may try to achieve 180. People have tried 200 versus 300, but definitely 200, 300 in this baby is going to be a problem. What would you monitor when you grade up feeds for this baby?
We have to monitor for the clinical signs of feed intolerance, stoma output, is there abdominal distension, and
Okay.
wa-
So do you know how much length was taken out in this patient?
it was around
Intestinal length?
20. It was around 20 to 25 centimeter.
Why is it important?
It is to know for the development of the complications like short bowel syndrome,
What is the minimum
post
bowel length required for enteral survival?
uh,
So that the baby
please.
tolerates enteral feed. What is the minimum bowel length which is required?
um,
So it is 30 centimeter with
that,
valve or more than 50 centimeter without valve, right?
oh,
Okay. And when would you say it is short bowel syndrome?
if the if the removed bowel length was around 15 per.
So any baby who is dependent on TPN, okay, for more than 3 months would be a short bowel syndrome,
Short bowels.
correct? Okay. What are
Yes.
the complications you are anticipating when the baby is on feeds? And suppose this baby develops feed intolerance, what could be the underlying pathology?
It can be redevelopment of feed intolerance as uh,
Could be
there
stricture,
can be a stricture. Yes, ma'am.
could be
Stricture can be
abscess.
there, and
Yeah,
sepsis
stricture very
can be.
likely. Yeah, abscess may develop intracutaneous fistula. These are complications, right? Post NEC surgery. Suppose this baby perforates and is not stable, you ventilate the baby and you start on inotropes. Okay, the same baby.
Yes.
What would be your treatment choice? You would go for what would you do? Baby has perforation, hemodynamically unstable. You ventilate. Now what would you do next?
For inotropic support,
You
we
started inotropic support. अच्छा सा echo किया है सब मस्त hemodynamic देखा है. You started inotropic support. BP is normal. Now what are you going to do next?
mm, mm,
Immediate treatment. Next, you stabilize the baby. Airway, breathing, circulation has been taken care of. There is perforation. What would you do next? What would you do? That perforation you would treat, right? You would do something with
yes,
that for that. So what would you do?
surgical.
So you would post the baby for laparotomy or you do
Yeah,
something bedside.
peritoneal drainage can be done.
Okay. So what would be your preference, peritoneal drain or laparotomy?
Laparotomy is more, but as this baby is sick, we can peritoneal drainage is preferable.
Okay, peritoneal drainage, you can, so because if the baby is hemodynamically unstable, PPD, primary peritoneal drain is the treatment of choice in there. Okay, ठीक है. So suppose this baby started on feeding and the surgeon has taken out around 40-50 centimeter of bowel with the intestinal valve. You started feeding and the baby has started pouring through the stoma. Okay, what is this happening?
Uh,
इंटेस्टाइन
is
लिंक निकाल
dumping.
दिया है, फीडिंग शुरू किया है, स्टोमा है, and there is huge output through stoma. What's happening to the baby?
It's a dumping mechanism. The baby is not. The absorption is not happening properly because there is a short bowel is there, and
Okay, so high output because maybe it's an acute phase of short bowel, right?
yes,
Okay, so what would you do here? Give TPN support, manage fluid electrolyte imbalance.
yes.
Okay, what is the second phase of short bowel? Recovery.
Second phase is recovery.
What happens there?
In this phase, there will be the baby will start tolerating the feeds, and the stoma output will gradually improve. The baby there will be less chances of there is no less electrolyte imbalance present over that, and it lasts for some time. It lasts for a longer period of
Okay.
time.
What about third phase?
Third phase is
Maintenance, where you
maintenance.
take out the TPN, right? And the baby does well. Okay, would probiotic was indicated in this patient?
Uh, Sorry, ma'am.
If
Pre
baby is
post
you are
op
in ICU and you have a policy of starting probiotic for preterm babies, so would you start probiotic for this baby?
uh yes, ma'am, we can start in this baby. As the it improve the gut flora, and it can help in the in the
For 34 plus 2 weeks, you would consider, or there's a
no,
separate
sorry, ma'am.
population less than
We
32 weeks,
generally
right?
consider the probiotics for less than 34 week of gestation.
Okay.
So in this
Quick,
baby,
quick questions on probiotic. If at all you start probiotic, which species? Combination. Quick.
yes, combination lactobacillus acidophilus and bacterophilus bovine.
Bifidobacter. Always combination, right?
Yeah,
What dose you would start?
uh, 10 10 raised to 10 million per kg per day.
3 multiplied 10 raised to 1 nines colony forming unit per day for less than 32 weeks and half for ELBW.
ELBW.
Correct? When would you start?
Start after 28 week of gestation uh, with
No.
the
When the neonate is ready for enteral feeds and preferably within 7 days. Okay?
okay.
How long to continue?
Till the baby is on full feed with tolerating the feed, and around at the 34th week of gestation till the gut maturity is
Okay.
present.
And when is it contraindicated?
In a sepsis,
Okay, sepsis NEC, right? Asphyxia. Okay. Well, last question. How would you follow up this baby?
uh, for follow-up, we have to monitor the baby's weight gain. For We have to see for there is the failure to thrive is present or not. Then uh, for stoma closure, we have to monitor the baby, and
So here you have to separate thing as a preterm low birth weight, you have a follow-up. And because the baby underwent surgery, you have a surgical follow-up, correct? So do
yes,
not forget our standard follow-up for preterm low birth weight, right? That
yes, ma'am.
includes your growth, Okay, ROP, hearing, development.
Development.
Okay, this has to, do not forget this. Okay,
Yes.
and then surgical point of view, the baby would be managed, would be followed up with the pediatric surgeon and your team, right? The neonatology team. Correct?
Yes.
Yes. Thank you, Ekta. Wonderful.
Thank you, ma'am.
Congratulations.
Thank you, ma'am.
Uh, Dr. Jatin, I think we are okay. Jatin, sir?
Yeah, ma'am. Yes, I think the time is 9:30. We still can take some questions if the audience wants to give in chat box. And meanwhile, they write any questions, sir. If any remarks from your side, sir. Ashish, sir.
Basically, this well code, I don't know whether the prevention of the NEC has been discussed or not. Most important will be the recent literature, the delayed cord clamping has been discussed as a preventive strategy, and the immunotherapy. That's second thing that is always to keep in mind for all this prematurity or the low birth weight or SGR related issues. And then people need to understand that initially during my fellowship days, the what's is it, the initial feeding was 10 to 15 ml per kg, a non-nutritive feeding. But then it has gone to 26 ml per kg per day from 10 ml per kg per to start with. And if the baby is otherwise coping up well, you can grade to 30 ml to 35 ml per kg per day. There is enough evidence on that. Having said that, as a clinician, we know that at times it is not possible if you do not have mother's milk. With mother's milk, yes, you can push it, but if no mother milk, then think twice before using those numbers. So it all depends on the individual thing. We need to have mother's milk, if not donor's milk. And then looking to the gut, looking to the baby tolerance, one to decide what will the grading like 20, 30, 35. That is what we can discuss on. And having said that, the definition of feed intolerance, that feed intolerance is a big heading, and when simple distension, one or two vomiting, that is one spectrum. Two, simple full distension, not passing stool and passing bilious vomiting, that's another spectrum. So one need to be very cautious about that. Actually, if you look at the feed intolerance, the most of the people will fit into that. And if you start following that, most of you will stay on the TPN and will stay on the null by mouth or half feeds. So one need to be very vigilant and think twice before stopping the feed on the babies. So that is one issue. And these are the babies like preterm, IUGR, abnormal flow, sepsis background. That where this is the place where simple feed tolerance also need to be taken seriously. So it is all clinician dependent decision whether to push the feeds on this kind of babies or not. When we received the baby, we thought that what is going to happen? The abdomen was looking very bad. The distension was there. Paresis is not typical baby, and we were in dilemma whether to put drain or to operate. Somehow we decided not to operate. Just wait for 3 4 days. We were sitting on the baby. It started becoming a lump. Abdomen started becoming soft. Platelets started improving. So that was the time when surgeon decided to intervene. Unfortunately, when he opened up, good amount of the bowel was sloughed off badly. Luckily, baby didn't show that when baby was not opened. The moment he opened, it was localized, but badly sloughed off intestine. So current problem or current our concern on this baby is that whether baby is going to develop short bowel or not, number one. And at this stage, still we are worried because peristalsis are not there, baby is not passing stool, bilious, vomiting, bilious, bile is keep on coming out. It's a long way to go. For same thing can happen to any baby with NEC. So it is surgeon decision at times whether to intervene or not intervene. If you look at the evidence between the peritoneal drainage versus laparotomy, doesn't make big difference if I'm not wrong. They show that, yeah, at times even sitting on the baby with peritoneal drainage at times causes problem. In the sense they were late in opening and then
Yes.
things are on other side. So again, there is a dilemma about peritoneal versus laparotomy, and it all depends on the surgeon or the unit where they are happy to handle this kind of babies or not. We had arterial line put on, we had a lot of fluid given during the surgery also, because at line we realized that a lot of volume support was required. Luckily, baby could sail through the surgery, but at this stage, 6 postoperative, still we are not sure whether baby is going to make it or not. And then we talk about the probiotics. Again, big dilemma started by our NRI friend Dr. Girish Deshpande and Patole. There are lots of ifs and buts. First of all, the way the sachets are being stored in our medical store, that's not the ideal way to do that. Ideally, all probiotics should be under the fridge and should be even transported under certain temperature, which is not happening. Again, we do not have ideal probiotic that we know. We just give the mixed formula, whether it's a research product or not. That also is doubtful. Shilpa mentioned about the dose. Yes, I fully agree with that. But again, there are so many ifs and buts about the probiotic. We had very high incidence of NEC, surgical NEC, before we started probiotic. That the moment we started probiotic in our unit, I don't say that everyone should take that, but in our unit, surgical anesthesia went down. But this was the time before our milk bank was there. The moment we have milk bank, things have settled like anything. So whether probiotic is working or my milk bank is working, that I don't know.
There is a
But
disclaimer. I
yeah,
agree with you, sir. Even though we've discussed probiotic, even we don't use probiotic because we have everything on milk bank.
yeah. So those who do not have milk bank and if their surgical anesthesia rate is high, I must say the probiotic should be used. But that should not be dictum for all the units, depend on your surgical rate. At times, what I teach my colleague or my sisters or the nursing staff, fellows, if you go on the racketies or the side corner cafes and eat a dirty food, you are going to get problem with the tummy. And same is true for my little ones, my small babies. So one to be very cautious about preparation of the milk, the temperature of the milk, the speed of the milk, and the hygienic practices of collecting that in the watties, sterilization of the watties. Small thing does matter. And anything that is distension, we always there was NEC. That may not be NEC. You rightly said spontaneous perforations, focal perforations. There are so many things which is differential diagnosis of NEC. It may be simple stress ulcer. At times, you said we feel a distant abdomen, fluid and air under the diaphragm. Turns out to be a simple gastric perforation. So there are so many differential diagnoses of NEC. And recently, I'm sure you were there for the recent Hippocrates. Doctor knew he had different outlook of the NECs. He said that it is the microbiome which are responsible for the NEC. And microbiome, they're friendly microbiome, and I don't remember the name of those fancy organisms, but there are for few good and few bad. And the moment you give antibiotics, the bad microbiome goes up, and that they causes all sorts of problem. And that's why the title of the talk was NEC revisited. It was he's saying that probably in the time to come, the abdominal distension or what we see NEC will not be acid, will be something else that we are going to label it. So it's a future for us, but for time being, one need to make sure that you are putting your things right. Things will do well. There are few dirty NEC babies, they do well, and there were good NEC babies, they may not make it. That is what the reality is. Thank you.
Thank you. Thank you, sir. It was very nicely explained. And I think you rightly mentioned feeding, aggressive feeding, mother's milk, that plays prevention is better than cure, obviously. And rightly, we got one question, very interesting. Why NEC is most common in 34 weeks of gestation? So
Is
Most
it true?
common.
interesting.
Is it true?
Why it is more common in 34 weeks of gestation?
But even I asked Shilpa and you both, is it true?
No. But sir, we do see bad NECs in the late preterms.
I know you are right.
We agree.
But it's not
Lower,
common.
yeah, it is not common. Lower the gestation, more is the incidence. However,
Yeah.
as Ashish sir just mentioned, if the gaps in the feeding at every step plus the risk factor, it adds up to the risk of NEC.
True. I think it is more seen that the standard feeding policy is very important in the unit. The policy varies from consultant to consultant. The NEC is invariably high with that unit. That is a very universal observation in most of the Western countries as well. And one thing is more
Yeah,
the
repeat what you're saying, Jatin. Repeat that.
standard uniform feeding policies. I
Yeah.
think one unit should have one policy. Suppose there are three consultants, three different regimes are being followed. That unit is going to have a more NEC compared to
Right. Perfect.
Very important. The other thing, like the ask 34 weeks. One observation is that the more the mature baby, the incidence is less, but the NECs are bad actually, and they come early.
Yeah.
Extreme preterms will have an NEC little later, I think after a few weeks. But this was in second, third day. I think this baby developed on third day of. So it came very early. Actually, to my surprise, this baby came on second day of NEC. So it could be sepsis-induced NEC itself. Early onset sepsis can lead to NEC.
Yeah, basically this is, see, that was that Robert Joe New was saying that it may be simple sepsis and paralytic ileus to begin with. The moment you start giving antibiotics, those microbiomes, they are culprit for the NEC. So NEC was not there to begin, it was sepsis and paralytic ileus followed by antibiotic induced NEC. That is how the chain happens. The typical NEC that we see is generally 2 to 3rd week of the life. They are on little bit of fits. Then you see typical necrotic bowel. Here you just slough out bowel. So having said that, pathology did show the necrotic bowels and all that. But looking to the incident at the time that it began, you are absolutely right, Jatin. This may not be NEC. This may be simple sepsis followed by NEC.
Yeah. One couple of more questions are there in chat box. Ma'am, what is FIP? Somebody is asked.
FIP is focal intestinal perforation.
Okay.
It is the same as SIP, but it's a more scientific name for SIP.
Okay, thank you. Probiotic sachet dosage in LBW and ELBW babies. Somebody wanted it to get repeated.
So probiotics, as we just discussed, it's not yet FDA approved.
Wow.
And also it is not the answer for prevention of NEC. If for the prevention of NEC, what is important is mother's own milk early, so delayed cord clamping. So antenatal steroids, delayed cord clamping, oral colostrum, mother's milk, grading of feeds, and preventing sepsis. If you follow this, the NEC is going to be definitely less. We cannot make it zero, but it would be low. The incidence is going to be low. Probiotic is not the answer for that. Probiotic is not FDA approved, but there is literature available for the dosage. And that is what I have mentioned, that for less than 32 weeks is 3 multiplied by 10 raised to power 9 CFU and 1.5 multiplied by 10 raised to power 9 CFU for ELBW.
See, basically, probiotic has remained a debate for years together. Last decade, each conference had this debate, and there are both the side of it. Depend on the unit, whether your surgical incidence is very high, NEC is very high. Yes, probiotic decreases surgical NEC incidence. It doesn't increase the NEC, it decreases surgical NEC incidence. So if you are having so many colostomies or laparotomies because of the NEC, better use it. But priority or the first thing is mother's milk, mother's milk, mother's milk. That is most important part.
But I think somewhere has been heard that probiotics will reduce the severity of NEC. I'm not sure how much it's evidence-based. But
it also depends upon the baseline risk of NEC in the unit as well as sepsis. If the unit has huge sepsis and NEC rates, then maybe it may show some reduction because it is going to replace the pathological bacteria in the flora.
Yeah, and the Cochrane does support that, and probiotic decreases the late onset sepsis also.
True.
So, yeah, that maybe, as I told you, it depends on the unit's own data. Whether they want to go for probiotic or not. It is not like antibiotic that all NEC could get probiotics.
One last question we have, sir. Please guide regarding cyclical feeding practice in feeding intolerance or in such post-operative case. What is cyclical feeding practice?
Is it continuous feeding? Is it continuous or cyclical?
It's just written as somebody has asked. Please
There is something called cyclical TPN.
Yeah.
Cyclical feeding, I am not sure.
I mean, cyclical feeding, TPN would have some holidays or something in that, I guess. Not sure about cyclical feeding.
Can you read the name who has asked the question?
Faisal Khan. Dr. Faisal.
He's written continuous feeding in the chat box again.
Okay,
he means that please guide regarding the continuous feeding practice and feed intolerance or such post-op cases.
Okay. So continuous feeding, if you look at the evidence, it doesn't actually make a difference. In fact, continuous feeding is said to cause some loss of fat and phosphorus during continuous feed, and it may also lead to delayed time to achieve full feeds. So, however, it is definitely recommended for ELBW who have some feeding intolerance and not definitely, but there is some evidence for that for feed intolerance and GER, reflux. So when we start continuous feeding, it is generally over 5 hours. Okay, that the volume over whatever feed you are going to give, you divide it over 5 hours. Per hour, you give that entire volume. Give a period of feed for an hour, and then again start feeds. So every unit has a different policy, but generally when we start, it is through syringe pump, and so it is given at a fixed rate over certain duration. That is how it is given. I mean, that is how we follow. If we at all we want to we have any patient for any patient for this, but I would like to hear from the other faculties also.
Are you giving it through nasojejunal or nasogastric?
So
Continuously?
transpyloric is not really it's really troubling, and it leads to all the disturbed physiology, and it leads to more harm. So we give it nasogastric.
Nasogastric.
Nasogastric if the baby is ventilated, orogastric if the baby is on non-invasive ventilation.
I mean, my personal experience is it doesn't make any difference actually. Won't reduce reflux as well. So stop doing that.
In small babies, particularly, I'm talking about babies below 27 weeks and
Yes.
talking about less than 600 grammars. At times, either you study 3 hourly feeds and then gradually go to 2 hourly feeds, and if required, go to 1 hourly feeds. But we have seen that then abdominal distension, because babies on NIV, these are the babies who are on the NI non-invasive ventilation, and then you are not sure whether the distension is because of the gut problem or because of the gas belly, because of the CPAP or HFNC. So in our unit, we start with the routine feed is 2 hourly interval to begin with, gradually grading to a level. But then it goes to half and half feeds. You start a lot of desaturation, the bradycardia related to reflux and all those things. So these are the situations where we prefer continuous feeding, because with that, what we have seen, maybe 2-3 days early there is to full feeds. So we can get off the TPA and central lines and all that little early with continuous feeding regime. And yeah, that's one. So for small babies, yes, we love it and we try to do that. Having said that, we understand that continuous feeding also has got nutrition losses. Number one, at times difficult to manage because you can't have formulas in that. You can have mother's milk only for the continuous feed, because formula will last only for half an hour to 1 hour once prepared. So formula, if the mother is not lactating, they are not signing for the milk bank donor's milk, then formula is the option, and formula will not go for the continuous feeding. Only human milk will go for the continuous feeding. So there are so many ups and buts, but depending on the situation, we take decision whether to go for bolus feeding, I mean gavage feeding, or to go for the continuous feeding.
I think there are no more questions. I think last one still came just now. Any difference between infusion and the bolus feeds to reduce the feeding intolerance by Dr. Nishchal?
Bolus versus infusion feeding, same, no?
Same, I think.
Same
Yeah, so we
answer given.
mentioned,
I think the answer has been given. So.
Bolus generally mimics physiological feeding, and continuous, as sir just mentioned, is for specific population where you face issues with desaturations, means reflux is a concern.
Yep.
When somebody has asked that, what is the duration of probiotics? How long to use that?
So maybe we can share the article in the group.
Yeah.
The entire article. Is that easy?
A lot of questions regarding the probiotics.
But as soon as the babies are discharged home, you stop
Basically,
it.
it is to be started once you are on the full feeds or near full feeds. And most of the unit where the is been practiced as a routine, they continue up to 32 to 34 weeks.
Yeah.
That is all. They stop at 34, that is for sure. But few units will stop at 32 weeks, because by that time the gut is mature enough, and generally incidence of NEC is less after 32 weeks in a given preterm baby. So that is where they end.
Okay. I think there are no more questions, and it's
बेसिकली
almost
34 के बच्चा आता तो माँ की गोद में जाना चाहिए, कैफीन और जितने सब लपड़े सब बंद कर दो, माँ का दूध पिलाओ और मल्टीविटामिन खिलाओ, दैट्स द थिंग.
nicely summed up, sir. So I think it's nearly 10, so we should be closing now. I think I would like to thank Dr. Ekta. Very nice presentation.
Thank you,
He
sir.
explained for 1 hour questions and did very well. And I would like to extend thanks to Dr. Shilpa ma'am for nicely taking up the case, Dr. Ashish sir and Dr. Dhiren actually for moderating the session so well. And I'm sure it has been very helpful to all the fellow faculties. And we will continue with the Noel series next week.
Thank you so much.
Thank you very much.
Thank you for the opportunity.
Thanks Jati and Dr. Gunjana. Thank you very much.
Thank you, sir. Thank